Okay, let's unpack this. Think about your own home for a moment. Maybe that one overflowing drawer or, the pile of clothes you swear you'll get to someday. Most of us have some clutter, right? It's a pretty universal experience. But today we're diving into a topic that many might think they understand, but, well, often gets profoundly misunderstood. Hoarding. It's far more than just being messy or having too much stuff, and it affects millions of lives, creating a significant distress and impairment.
And that's really where the critical distinction lies. The casual term hoarding gets thrown around so frequently, often conflating everyday disorganization with something far more serious and deeply impactful. Our mission with this deep dive is to use the insights from our comprehensive sources to precisely define what hoarding disorder truly is. We want to differentiate it sharply from casual collecting, explore its complex roots from deep psychological patterns and cognitive challenges to fascinating neurophysiological underpinnings. And crucially, to examine the evidence-based treatment approaches that are making a real difference, especially those tailored for midlife and older adults. This is really about cutting through the noise to deliver critical, actionable understanding of a profoundly impactful condition.
So if it's not just being messy or, having a sentimental attachment to a few things, what is hoarding disorder? Our sources point to the DSM-5 criteria, which really sets a clear clinical framework for what we're talking about, right? Formalizing it as a distinct condition.
Indeed. Yeah, the DSM-5 formally recognizes hoarding disorder as an obsessive-compulsive spectrum condition. And this is a significant development because it clearly distinguishes it from general clutter or even other disorders it was once associated with, like obsessive-compulsive disorder or OCD. You see, historically, hoarding was often considered just a symptom of OCD, but this independent classification means we can now understand and treat it as its own entity with unique characteristics. So what are the core elements that truly define it? Let's think of it as maybe a three-part puzzle, one that has profound internal and external consequences. The first piece is a persistent, intense struggle to discard or part with possessions, regardless of their actual value. This is crucial. It's not about the monetary worth of an item. It could be an old newspaper, a broken appliance, or, I don't know, a shampoo bottle. But it's the intense internal discomfort and almost crippling emotional struggle tied to the act of letting go. Okay, so the second piece of the puzzle is why this difficulty exists. It's due to a perceived need to save the items and significant distress associated with discarding them. This is where the individual's internal world becomes, well, paramount. There's a profound, often overwhelming personal connection to these objects that prevents them from letting go. The reasons for saving are varied and deeply personal. They can be sentimental, where an individual might say something like, "This represents my life, it's part of me," signifying a deep, almost identity-level connection. Or they could be instrumental, driven by the thought, "I might need this someday, somebody could use this." Here, it's about perceived future utility, even for items that seem useless to an outside observer. And then there's the intrinsic reason. This is beautiful. Think of the possibilities. This reflects an aesthetic appreciation or a perceived potential in an object, even if that potential is never realized. And finally, the third piece. The sheer accumulation of possessions clutters active living areas and substantially compromises their intended use. This is where the disorder becomes visibly impactful. Our sources really emphasize clutter as a key visual indicator. If living areas are somehow uncluttered, it's only because of intense, often unsustainable interventions of third parties like family members, professional cleaners, or even authorities sometimes. Imagine trying to cook in a kitchen where the counters and stoves are buried, or sleeping in a bed piled high with items, or even just moving through your own home via these sort of maze-like pathways. The space simply stops being functional for its intended purpose.
So it's not just about the stuff, but the why someone keeps it, the internal struggle, and the severe impact it has on their life and environment. That makes so much more sense when you break it down like that. But what about the overall effect? When does it truly become a disorder?
That's precisely the point. That's where these elements coalesce into a diagnosis. The accumulation and struggle cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, including, and this is critical, maintaining a safe environment for oneself and others. This is key for it to be recognized as a disorder, differentiating it from someone who simply has a very messy house but isn't really distressed by it. The impact goes way beyond aesthetics. It truly affects their daily life, their relationships, their ability to work, and can pose serious health and safety risks like fire hazards or sanitation issues. Furthermore, it's critical that the hoarding isn't attributable to another medical condition, things like a brain injury or Prader-Willi syndrome. nor is it better accounted for by symptoms of another psychiatric disorder like, obsessive compulsive disorder, major depressive disorder, or dementia. This nuanced understanding ensures it's treated effectively as its own distinct condition.
That paints a really detailed picture of the internal and external realities. And our sources also talk about how people acquire these items that eventually contribute to the clutter. It's not just stuff they've always had, right?
It's exactly. Yeah, excessive acquisition is often a specifier within the diagnostic criteria for hoarding disorder, meaning it's a specific way the disorder manifests for some individuals. It encompasses various behaviors beyond just inheriting or passively receiving things. This can manifest as compulsive acquisition, which isn't just regular shopping, it's an overwhelming urge to buy. Whether from retail stores, online platforms, or home shopping networks, often for items not truly needed or for which there's no space. It also extends to the acquisition of free things like flyers, giveaways, or even engaging in trash or dumpster diving. In more severe manifestations, it can unfortunately include stealing or kleptomania. Beyond how items are acquired, it's also important to understand the individual's level of self-awareness regarding their problem. This is captured by insight specifiers. Someone with good or fair insight recognizes that their hoarding-related beliefs and behaviors are problematic. They know it's an issue, even if they struggle to change it. Then there's poor insight, where the individual is mostly convinced that their hoarding-related beliefs and behaviors are not problematic, despite clear evidence to the contrary from their living situation or the impact on their life. And the most severe level is absent insight, which sometimes involves delusional beliefs. In these cases, the individual is completely convinced their beliefs and behaviors are fine, regardless of overwhelming evidence. This spectrum of insight plays a huge role in their willingness to seek and engage in treatment.
So when we understand these layers, the persistent difficulty discarding, the perceived need to save, the functional impairment, the varied acquisition behaviors, and the level of insight, it really paints a comprehensive picture. And the critical insight here, it seems, is that hoarding disorder isn't just about what someone keeps, but why they keep it, and critically, the impact it has on their daily life and safety. It's a profound internal struggle with really significant external consequences. Here's where it gets really interesting, and frankly, it's a common self-diagnosis or misunderstanding people might make. One of the biggest misconceptions is confusing hoarding with collecting. I mean, who doesn't collect something? Stamps, coins, vintage records. I certainly have a few collections that might make some people raise an eyebrow. But our sources draw a very sharp line between these two behaviors.
That's a great point, and it raises an important question for many. When does a passion become a problem? The numbers alone are pretty striking. Our sources tell us that roughly 107 million Americans collect one thing or another. Compare that to a far smaller number, somewhere between 6 and 15 million, who struggle with hoarding. That's a huge difference in prevalence, right? And the distinction isn't just semantic. It's about well-being, quality of life, and whether a behavior is enriching or deeply impairing. The defining distinction, according to the research, specifically from Ashley Keller and her team at King's College London, it's fundamentally about the levels of organization. Think about it. Collectors engage in what's described as ritualistic behavior around organizing their items. They curate their collections, they preserve them, and they often proudly display them. It's a purposeful activity, often driven by passion, the desire to learn, or even as an investment. Their items are usually well organized, accessible, and they often have a clear idea of what they have and where it is. On the flip side, hoarders exhibit an indiscriminate acquisition process with a distinct lack of emphasis on organization. Items are just chaotically accumulated without a clear plan, often in massive, disorganized piles. To give you a clearer image, imagine a Reddit anecdote from our sources. It's about a person who claimed to be collecting computer books and back issues of computer magazines. This person filled shelves, then stacked boxes of these books on the floors until they reached the ceiling. Their living room was no longer a living room. It was just storage for this collection. Then the accumulation spread to half the den, part of the kitchen, and even one of the kids' bedrooms. This individual insisted they were collecting, but they never curated their items. They kept every single computer book or magazine they could get their hands on, irrespective of duplicates or actual utility. In stark contrast, a true collector of, say, rare books or maybe tarot decks would have designated organized spaces on bookshelves. Their items would be labeled, displayed, easily accessible. They wouldn't feel compelled to acquire every single item, but would focus on specific goals for their collection. They might even sell or trade items with other collectors to refine their collection. It's about curation and functionality versus, indiscriminate accumulation.
That's such a vivid example of the difference. So it really comes down to whether the items enhance or impede life. And I imagine that leads us directly to the impact on living space.
Precisely. For collectors, while their collections might take up significant space, they generally do not impede the proper functioning of the home. Consider the historical example of Louise Herreshoff and Euclid Reeves, a couple intensely passionate about collecting porcelain and art. They actually bought a second house next to their own, specifically for their amassed objects. While they lived in relatively cramped quarters themselves, the key distinction is that they curated high-end treasures and lived a full shared life through collecting together. They chose that arrangement. It wasn't imposed by chaos or an inability to discard. For hoarders, however, the accumulation of possessions impedes the proper functioning of their homes. This severely affects their daily activities, relationships, and safety, causing the clinically significant distress or impairment that defines the disorder. There's also a significant difference in emotional attachment and psychiatric diagnosis. Our sources highlight that most individuals with hoarding disorder carry at least one other psychiatric diagnosis. Over 50% with major depressive disorder, around 25% with generalized anxiety disorder and/or social phobia, and fewer than 20% with OCD. Hoarders form strong, often problematic emotional attachments to their items, seeing them almost as extensions of themselves or feeling immense guilt about discarding them. Collectors, while they may also have emotional connections, typically relate these to the joy of collecting, the thrill of the hunt, and the significance of the items within their curated collection. Not intense distress at the thought of discarding, collecting is generally considered a healthy, enjoyable pastime, providing enduring benefits, not a mental disorder.
That's a crucial distinction. And I read something in the sources about a property size paradox, that collectors tend to have larger properties than hoarders. That seems, well, counterintuitive if hoarders have more stuff.
It is, yeah, and it's an intriguing finding from Keller's research. This observation has two sort of conflicting interpretations. One is that individuals with hoarding disorder tend to have smaller properties because their prolonged psychiatric condition impacts their career or ability to work, limiting their housing options. The other interpretation suggests that because one of the criteria for hoarding disorder is that your living space is impeded, well, it simply takes longer for someone with a larger home to meet that specific diagnostic stage, as they have more initial space to fill before it becomes a clinical problem. Either way, it highlights the real-world impact of the disorder. Finally, the motivations for collecting go far beyond what we see in hoarding. For collectors, it's often about fun and goal setting, the clear, obtainable goals, the hunt, the thrill of adding items. It fosters social connection, forming communities, sharing knowledge, even competition, leading to a strong sense of belonging, like a football fan collecting memorabilia. There's also a powerful pull of nostalgia and preservation, connecting with bygone eras or personal memories from trips. While, early psychoanalysts like Werner Musterberger suggested deeper psychological motives, such as compensation for a lack of relationships. Today, experts generally view collecting as enriching life in a real way.
It's fascinating how a subtle difference in behavior, like the act of organization and the impact on living space, can signify such a profound difference in mental health. It really underscores the importance of proper diagnosis. The critical insight here seems to be that collecting is a purposeful, organized, and often social activity that enhances life. Whereas hoarding is characterized by disorganized, indiscriminate accumulation that impairs daily functioning and causes significant distress. But let's dig into why someone might develop these hoarding behaviors. What are the underlying mechanisms?
Building on that, understanding the mechanisms that drive hoarding is absolutely crucial for effective intervention. Gail Steketee and Randy Frost's cognitive behavioral model, developed back in 2007, offers a fantastic roadmap for why people hoard. It proposes that hoarding arises from a complex interplay of vulnerabilities, information processing deficits, the meaning assigned to possessions, and powerful emotional reactions. Let's start with vulnerabilities. These are the predispositions an individual might have. Our sources mention evolutionary, biological, and genetic factors, suggesting a foundational susceptibility. Early life experiences also play a significant role, such as attachment issues or childhood deprivation, which can profoundly shape one's relationship with possessions. Furthermore, core beliefs, often developed from these early experiences or family environments, can perpetuate hoarding. We see examples like waste not, want not, and ingrained perfectionism, or the belief I have to give my son what I didn't get. Neat. Think about the 54-year-old woman in our sources whose father modeled hoarding behavior. This early exposure likely contributed to her adopting a waste not, want not core belief, which then became a significant vulnerability for her own hoarding behaviors later in life. Central to this model are information processing deficits. These are foundational cognitive challenges that make managing possessions incredibly difficult. We'll delve into these in more detail shortly, but broadly, They involve problems with decision-making, attention, memory, and problem-solving. These aren't just minor inconveniences, they're significant hurdles to everyday organization and discarding, making it feel almost impossible for the person. Then there's the meaning and value assigned to possessions. Individuals with hoarding disorder often imbue their items with profound significance. This can relate to their identity. This represents my life. It's part of me. Perceived utility, a strong sense of frugality, feelings of responsibility for objects. Their role as memory aids or beliefs about the uniqueness and completeness of their items. Perfectionism also plays a role here, where items are kept because they might be part of a perfect collection or because they fear making an imperfect decision by discarding. All of these factors interact with powerful positive and negative emotional reactions. When an individual acquires or saves an item, they often experience positive emotions like pleasure, excitement, pride, relief, joy, fondness, or satisfaction. This acts as powerful positive reinforcement, encouraging the behavior to continue. Conversely, the thought or act of discarding items triggers intense negative emotions, such as grief or loss, intense anxiety, sadness, guilt, anger, frustration, or confusion. By saving the items, these uncomfortable feelings are reduced, which acts as negative reinforcement. This means the act of holding on to something makes them feel better by avoiding unpleasant emotions. For example, the 54-year-old woman we discussed, who saved cosmetic samples and shampoo bottles. She felt a strong sense of responsibility and guilt about potentially wasting them. Saving these items reduced her discomfort, negatively reinforcing the behavior. Similarly, her guilt, anxiety, and sadness about her son's worn-out toys led her to save them, again reinforced by the reduction of those negative feelings. This creates a persistent reinforcement loop, where acquiring and saving behaviors are continually strengthened by both the pleasure they bring and the avoidance of discomfort, perpetuating the clutter cycle.
So these cognitive challenges seem like a huge piece of the puzzle. It sounds like it's not just about a lack of willpower, but almost like their brain is literally struggling with the very act of sorting and deciding. Is that a fair way to put it, or am I oversimplifying? Can you give us a more concrete picture of these specific deficits?
You're absolutely hitting on a crucial point there. It's not about willpower. It's about genuine neuropsychological deficits that make managing possessions incredibly difficult for individuals with hoarding disorder. Let's start with attention. Clinicians have long observed that hoarders are very distractible. They often require extensive prompting just to stay focused on a task, whether it's organizing or engaging in therapeutic exposure. Research confirms this. Studies have found increased ADHD symptoms in individuals with hoarding compared to control groups. Furthermore, laboratory tests show they have difficulties with sustained attention, meaning maintaining focus over time, and spatial attention, which is the ability to efficiently process visual information in their environment. Imagine trying to sort through a huge pile of items when every single object or even, a shadow on the wall can pull your focus away. It's incredibly challenging. When it comes to memory, individuals with hoarding problems often express a strong need to keep items in sight to avoid forgetting them. They report poor confidence in their memories and tend to overestimate the negative consequences of forgetting something important. While there's some variability in research findings, some studies indicate impaired, delayed recall and difficulty with copy organization. For instance, on tests like the Ray-Austriath complex figure test, where they struggle to reproduce a complex image from memory. There's also some evidence for difficulty retaining verbal information over time. These memory concerns often drive the impulse to keep everything visible, contributing directly to the clutter because they fear if it's out of sight, it will be forgotten forever. Perhaps most impactful are the deficits in executive functioning. Think of your executive functions as the brain's CEO, responsible for planning, organizing, making decisions, stopping impulses. In hoarding disorder, it's like that CEO's office is constantly in chaos, making those basic managerial tasks incredibly difficult. Hoarders often exhibit impaired inhibition, meaning difficulty suppressing impulses, like acquiring new items or the urge to save something. They struggle with planning and decision-making, which is evident in their inability to initiate and complete tasks, and their pervasive indecision about what to keep or discard. This also manifests as poor self-regulation, an inability to suppress acquiring or saving responses, and difficulty sustaining the motivation needed for discarding. A significant manifestation of executive dysfunction is in categorization problems. Instead of creating broad, efficient categories like kitchen utensils or documents, hoarders tend to create too many small, under-inclusive categories. This contributes directly to the disorganization and overwhelming clutter. Studies show that when asked to sort items, hoarders take more time, create more piles, and experience significantly more distress compared to non-hoarders. This isn't just a lack of skill, it's a fundamental cognitive hurdle.
That's a really clear picture of the cognitive side, showing how these issues aren't just about willpower. If someone's brain is literally struggling with these fundamental tasks, it makes so much more sense why discarding is so hard. But our sources also delve into the actual brain activity, what's happening inside the brain that might contribute to this.
That's another fascinating aspect, yeah. How neurophysiological research corroborates these cognitive observations, suggesting specific neural underpinnings for hoarding behaviors. It connects the what we see behaviorally and cognitively to the where in the brain. The research primarily highlights dysfunction in two key regions, the anterior cingulate cortex, or ACC, and the precentral and superior frontal gyri. Let's start with the anterior cingulate cortex, ACC, and associated areas. Think of the ACC as your brain's sort of error checker and decision maker. It's constantly monitoring, flagging potential mistakes, helping you choose. The dorsal part helps with error monitoring and reward-based learning, while the ventral part assigns emotional and motivational importance. Given that hoarding disorder is characterized by an inability to make decisions, heightened vigilance for errors, and overwhelming emotions, well, it's not surprising that this region is implicated. Studies have shown lower resting ACC activation in hoarders compared to healthy controls and even non-hoarding OCD patients. But here's where it gets really interesting. The pattern changes significantly depending on the object's ownership. When hoarders are deciding about novel, unowned objects, their ACC activation is significantly lower, suggesting a relative unresponsiveness in this area. But when they're deciding about owned possessions, ACC activation is significantly higher. This hyperactivity is observed during virtual acquiring, during in vivo discarding, and is even more pronounced when they refuse to discard an item. The critical insight from this brain research is that for hoarders, the brain literally lights up differently when they consider discarding their own possessions. It helps explain that intense, almost biological resistance to letting go. High ATC activity is often correlated with those not just right feelings, that deep sense of unease or imperfection that drives the avoidance of discarding. Now let's look at dysfunction in the precentral and superior frontal gyri. These regions are largely involved in planning and executing movements, like deciding to pick something up or put it down. So when we see abnormal activity here, it's very telling. Research shows patterns of abnormal activation here as well. For instance, hoarding-related anxiety positively correlates with left precentral gyrus activation when hoarders are imagining discarding novel objects. We also see hyperactivity in the precentral gyrus during the act of acquiring, and in the superior frontal gyrus during the discarding of novel objects. Most compellingly, there's a significantly higher activation in the precentral gyrus when individuals with hoarding disorder refuse to discard their possessions, compared to when they successfully discard them. This pattern, alongside the ACC findings, strongly suggests an exaggerated neural response in these regions when hoarders face decisions about their own possessions. It provides a neural underpinning for their profound difficulties with discarding. It's not simply a choice. There's a very real biological process contributing to their distress.
Given how deeply rooted these issues are, from cognitive processing challenges to specific brain activity patterns, it's not surprising that treating hoarding has historically been described as quite difficult. What are the specific hurdles clinicians face? And, for someone listening, it might sound almost insurmountable.
It's true, there are significant challenges. Historically, hoarding symptoms were actually thought to predict a poor response to standard obsessive-compulsive disorder treatments, and even certain medications. That immediately tells you how unique this condition is. Let's first talk about general challenges in treatment. A major hurdle is the lack of insight and motivation many individuals with hoarding disorder report. They often experience little distress or insight into the problems their behaviors are causing, which can lead to high levels of family frustration and a reluctance to even engage in treatment. This often translates into treatment refusal and inconsistent engagement, making it difficult to maintain progress. Furthermore, there's a high rate of comorbidity, meaning co-occurring conditions like depression and anxiety. These can complicate treatment, as clinicians must address not just the hoarding, but also the underlying or coexisting mental health issues.
And our sources highlight that these challenges can be significantly amplified for older adults, making treatment even more complex. Are there specific challenges you hear families often complain about that these therapies aim to directly address?
Absolutely. Yeah, as our population ages, we're seeing more cases of hoarding disorder in midlife and older adults who face additional layers of complexity that truly require tailored approaches. These specific challenges are significant. The role of family members and other social supports can be crucial, but also, unfortunately, a source of conflict when family attempts to intervene are met with resistance. Limited or fixed income is another practical challenge, impacting their ability to afford professional help or to manage housing and clear out spaces. Many older adults are already dealing with multiple medications and multiple medical providers, creating a complex health profile that needs careful navigation. Furthermore, older adults are more likely to have experienced possible negative life events that can trigger or exacerbate hoarding. This includes the death of a spouse, which can lead to inheriting items from the deceased, or personal illness and loss of independence. These events can intensify emotional attachments to possessions. A very significant motivator, but also a source of immense fear, is the risk of losing independent living status if the home becomes uninhabitable or unsafe. This could be a huge driver for seeking help, but also a source of immense anxiety. Then there are aging-related changes themselves. Cognitively, we often see a natural decline in executive functioning, memory, and attention, which, as we just discussed, are precisely the areas impacted by hoarding disorder, making organization and decision-making even harder. Emotionally, there can be increased object attachment due to heightened sentimental beliefs, memory concerns, fearing they'll forget if they discard an item, and issues related to identity. I am what I have. Physically, declining mobility can severely impact an individual's ability to organize, clean, or move items, further contributing to the accumulation and disorganization. All these factors combined make treatment for older adults particularly nuanced and demanding.
So, given how layered and complex these issues are, how do clinicians even begin to assess the scope of the problem when it's so deeply rooted? It sounds like you'd need a pretty thorough approach.
You absolutely would. Yeah, getting a precise understanding of the individual's situation is paramount. A thorough assessment battery is essential to accurately diagnose and tailor treatment. Our sources recommend a comprehensive approach that includes diagnostic tools, hoarding-specific measures, and additional assessments tailored for geriatric patients. For diagnostic tools, clinicians typically use structured interviews, like the Structured Clinical Interview for DSM Disorders, SCID, or the Anxiety Disorders Interview Schedule, ADTS. These are essentially very detailed, standardized conversations to confirm a diagnosis and identify any co-occurring conditions. Then there are specific hoarding-specific measures. The hoarding interview developed by Stickty and Frost is a crucial tool for a deep dive into the client's history and specific behaviors. For measuring severity, tools like the Hoarding Rating Scale, HRS, and the Saving Inventory Revised, SIR, are used to quantify the extent of difficulty discarding, excessive acquisition, and clutter. A particularly visual and impactful tool is the Clutter Image Rating. This uses a 9-point scale with pictures depicting varying levels of clutter, from pristine to completely impassable. Clinicians use these images to rate the clutter in specific rooms, helping them and the client see the functional impairment. Finally, the ADL hoarding, ADLH, is used to assess how hoarding affects activities of daily living. This measures the impact on practical tasks like preparing food, using the refrigerator or stove, moving around the home, exiting quickly, and finding important things. This helps quantify the real-world functional impairment caused by the clutter. For additional geriatric-specific assessments, given the unique challenges older adults face, clinicians use tools like the Geriatric Depression Scale and Geriatric Anxiety Scale to specifically measure depression and anxiety normed for this age group. To assess cognitive changes, neurocognitive measures like the Montreal Cognitive Assessment, MoCA, which is a quick screen for general cognitive function, and the Dellis-Kaplan Executive Functioning System, DKEFS, which dives deeper into things like planning, problem-solving, and attention, are employed. Lastly, additional functional measures like the Functional Disability Index are used to get a broader picture of overall daily functioning beyond just the direct impact of hoarding. This comprehensive assessment ensures that treatment plans are highly individualized and address all facets of the person's condition.
It's clear that a one-size-fits-all approach isn't going to work for a condition this complex, especially with those layered challenges for older adults. But our sources offer real hope, detailing specialized cognitive behavioral therapy, or CBT, and even more tailored approaches. So what exactly does the specialized CBT for hoarding disorder look like?
What's truly exciting here is how CBT has been specifically adapted to address the unique challenges of hoarding, moving beyond traditional OCD protocols. It directly targets the 4 core problem areas we discussed earlier: information processing deficits, excessive emotional attachment, behavioral avoidance, and problematic beliefs about saving and possessions. The first step is education and case formulation, also known as psychoeducation. This involves teaching the client about the cognitive behavioral model of hoarding, helping them understand why they do what they do, connecting their thoughts, feelings, and behaviors. There's a thorough discussion of the treatment process and what effects they can expect. Crucially, it involves personalized model building. This starts with the client's own explanation of their hoarding, and then the clinician adds features based on interviews and experiments. They work together to identify feelings, specific beliefs, and deeper core beliefs, connecting these directly to the acquiring and saving behaviors and the resulting clutter. This also links their vulnerabilities to these feelings, beliefs, and behaviors. Functional analyses are performed for individual features. For instance, our sources give the example of Susan's model, which integrates her emotions, beliefs about possessions, vulnerabilities, cognitive challenges, and how she saves and acquires items, and how all these aspects reinforce her hoarding behaviors. Next, clinicians help to establish personal goals and values. This is absolutely crucial for motivation. What does the client care most about? Is it family, friends, honesty, achievement, or something else? And what do they most want to do in the remainder of their life? For Susan, her goals included enjoying her musical instruments again, creating breathing space and order in her bedroom, having a living room where friends or family could enter, having a safe and functional kitchen, taking a bath, and removing bagged items that were cluttering her home. These personal goals are referred to throughout treatment to clarify any ambivalence the client might feel and to continually increase their motivation for change. This comes the vital step of motivating change. This involves recognizing, enhancing, and helping the client resolve their ambivalence about changing their hoarding behaviors. Drawing on the stages of change model, from pre-contemplation, contemplation, preparation, action, to maintenance, the clinician works to reinforce change talk and any actions the client takes, no matter how small, towards addressing their hoarding. This empathetic and collaborative approach is fundamental to getting the client on board, especially given the low insight some individuals might initially have.
That sounds like a very empathetic and structured start. Once someone is motivated and understands the framework, how do they actually begin the physical, often overwhelming process of decluttering? It's one thing to understand, another to physically act on it.
That's exactly where the rubber meets the road, and it raises an important question about practical skills. It's not just about willpower. It's about learning concrete strategies and changing deeply ingrained habits. The treatment includes specific skills and a plan for organizing. First, there are rules for clinicians and coaches working with clients. They always ask permission before touching items, ensure the client feels respected and in control. They help clients decide on their own rules for acquiring, keeping, and discarding items, empowering them in the decision-making process. The clinician resists the urge to choose for them, instead providing information and guidance to help clients learn to make these decisions themselves. And critically, they develop a systematic plan that moves through the home, either by room or by type of spaces and door objects, to make the task less daunting. For the physical process, the plan involves categorizing and organizing wanted items. This means identifying clear categories for different types of items and then selecting designated locations for these categories. They also discuss appropriate storage locations and furnishings. Importantly, they select interim sorting locations to manage items during the decluttering process. Simultaneously, they work on categorizing unwanted items into clear piles for trash, recycling, donating, or selling, with very few items left in an undecided pile. A crucial part of this is developing an action plan for immediately removing these unwanted items. The immediate removal part is key, no second guessing. Finally, because hoarders are often very distractible, the therapy includes skills to manage attention. Clinicians first determine the client's usual attention span. Then they help the client reduce or delay distractibility by using tools like a timer to set focused work periods, or controlling the visual field by covering distracting areas. They also discuss ways to create structure, such as setting regular appointments for sorting, establishing clear priorities, and dividing large projects into manageable steps. This structured approach helps overcome those inherent cognitive challenges we talked about.
So that's how they deal with the current stuff. But what about the acquiring of new things? How do they stop the inflow of items that often perpetuate the problem?
That's a critical piece, yeah, and it's fascinating how specific behavioral practices are designed to break the acquisition cycle, especially for compulsive buying. The first step is to identify the specific acquiring problems the client is facing. Then, the clinician helps the client develop a hierarchy from easier to harder behaviors related to not acquiring. This might start with driving past a store without going in, then standing outside the store, walking into the store without buying, seeing something they want, touching an object they want, putting it back, walking away from the item, and finally, walking out without the object. This gradual exposure helps to desensitize them to the urge to acquire. It's like building a new muscle for restraint. Alongside these behavioral practices, they work to modify beliefs about acquiring. This involves challenging the underlying thoughts that drive the need to get new items. A crucial practice is practicing not acquiring. This includes drive-by non-shopping, where they drive past places they usually acquire things without stopping, or walk-through non-shopping, where they walk into a store but don't buy anything, and browsing and picking non-shopping, where they might look at or touch items but don't take them. Another important element is coping with empty space, addressing the discomfort or anxiety that can arise from not acquiring new things. This can be a huge hurdle, as empty space can feel unsettling after years of clutter. To guide decision-making for new items, clients are taught to ask themselves specific acquiring questions and rules. Questions like, do I have an immediate use for this? Can I get by without it? Do I want it taking up space in my home? Is this truly important, or does it just seem so because I'm looking at it? And what are the advantages and disadvantages of acquiring this? Based on these questions, they develop personal rules for acquiring, such as needing to have an immediate use for the item, having time to deal with it appropriately, having the money to afford it, and critically, having the designated space to put it. This structured approach helps them make intentional decisions rather than impulsive ones.
And then, arguably, the hardest part for many people, the actual discarding of items. How do they tackle that deep-seated difficulty? Because from what we've heard, that's where a lot of the emotional distress is centered.
Precisely. Yeah, this is where cognitive restructuring becomes vital, challenging the deep-seated beliefs that fuel the saving behavior. It's a delicate process, often using Socratic questioning to help clients examine their own logic, almost like a detective. For treating difficulty discarding, there are general strategies clinicians use. Clients are often asked to bring a box of things from home to sort in the office, starting with easier items to build confidence. They are encouraged to talk aloud about their decision-making process, allowing the clinician to understand their thought patterns. Assistance with decisions is gradually reduced as the client gains skill. Clients also practice sorting at home, focusing on the most important areas and easiest items first. A critical rule is to immediately move sorted items to their destination or out of the home, no looking back, preventing second-guessing. This breaks that cycle of doubt. The core of this work is Socratic questioning, which helps both the clinician and the client understand the logic behind their saving, identifying correct cognitive distortions, and challenge those problematic beliefs. Techniques include the downward arrow technique, which explores core fears, analyzing advantages and disadvantages, pros and cons, of discarding, taking another perspective, using behavioral experiments to test beliefs, and considering the value of their time. They work to identify problematic beliefs such as fears of making mistakes or bad decisions, confusing need versus want, feeling excessive responsibility or guilt for objects or even people connected to the objects, anxieties about lost opportunities, reliance on objects as memory aids due to poor memory, seeing items as extensions of their identity, I am what I have, believing items are unique or one of a kind, striving for completeness or perfectionism, and a strong need for control. It's mine, no one can touch it. The clinician guides the client through questions to help think it through. How likely is the feared outcome if you discard this? What evidence is there to support your belief? How catastrophic would this really be? How well could you cope with not having this? How much distress would you feel, and for how long? Can you tolerate the feeling? And importantly, is your thinking coming from something or someone in your past? These questions help clients logically confront their anxieties and reevaluate their beliefs. Let's maybe walk through a detailed case example from our sources, illustrating Socratic questioning. It involves the 54-year-old woman we mentioned earlier, specifically regarding her 16-year-old son's worn-out toy. The clinician might start by asking, how about getting rid of this toy from your son's room? The woman responds, that would be hard. What is the hard part? The clinician asks. I'd feel like I was getting rid of something he might want in the future, maybe for his own kids. Okay, what condition is this toy in? Well, it's sort of worn, probably not very good condition. If you tried to sell it, would someone pay money for it? No, I don't think so. It's dirty and broken. Oh, okay, I agree. It seems unlikely anyone would buy it. Do you think your son would want to give his kids a dirty, broken toy? No, I guess not. The clinician senses deeper feelings. You sound unsure. Is there something else you are thinking that makes you want to keep this? Maybe some ideas in the back of your head? The woman admits, yeah, I'm feeling like I didn't help him take care of this toy. I should have been better protecting his things. This uncovers a layer of guilt. Okay, so you are thinking you'd have been a better mother if you'd helped him take better care of his toys. Do you believe that good mothers make sure their kids keep their toys in good condition? No, I know that isn't true. Kids have to play with their toys, and toys get worn and broken. So actually, it's okay that this toy is worn and broken. Is that what you believe? Yes, I do. But somehow I still feel guilty. Maybe I'm feeling bad for the toy. This is an interesting cognitive distortion, empathy for an inanimate object. The clinician addresses this directly. Oh, bad for the toy. Do you think the toy has feelings? What's it made of? Just plastic. I know it doesn't make sense, but the idea is there. So we need to examine that belief that the toy might have feelings. What do you think? Huh. I know it doesn't really have feelings. Are these feelings coming only from you? You said you felt guilty. What do you think the guilt is about? I feel that I need to provide my son with things I didn't have as a child. My own childhood was hard and I didn't have many toys. Throwing this out seems wasteful. This reveals a core belief linked to childhood deprivation. Let's take a hard look at whether it is truly wasteful. How would you decide that? When is it wasteful to get rid of something and when is it okay? Well, it's bad to get rid of stuff that's still useful, but okay to get rid of worn-out things. What about this toy? Does it meet the definition of worn out? You said you thought it was dirty and broken. Does that qualify as worn out? Yeah, it's really worn out. I need to get rid of this. This is a significant breakthrough. What about your guilt feelings? I just need to let this go. He doesn't want the toy. I know that. I just have to figure out why I feel so guilty. The guilt is not about the toy itself, but something deeper she acknowledges she needs to explore. I agree with you that it makes sense to get rid of this toy, and it seems like your guilt isn't really about the toy itself. Maybe it will become clear to you, but for now, shall we put it in the trash bin? Yeah, I'll get used to it. How about I ask you in a few minutes how guilty you feel? What is it now, at the start on a 0-100 scale, where 100 is the most guilty you've ever felt? It's a 60, I think. Okay, I'll ask again in a little while to see if you feel better. This detailed step-by-step process helps the client dismantle deeply held beliefs and tolerate the discomfort of discarding.
That example really brings to life how complex the internal process is. Wow. It's not just about getting rid of stuff, but working through those deep-seated feelings and beliefs. And our resources point out that for older adults, standard CBT might not be enough due to those cognitive changes we discussed earlier. So if neurocognitive deficits are present, especially with aging, how do we address them directly?
That's a crucial question, absolutely. And it's addressed by combining traditional CBT with specific cognitive rehabilitation strategies. This integrated approach is known as cognitive rehabilitation and exposure sorting therapy, or CREST, specifically for older adults. Its theoretical basis comes from programs like CogSmart, which emphasizes two key principles. First, cognitive compensation, which means working around deficits. Think of it like using a cane to support a weak leg. It's finding different strategies or even utilizing different brain areas to achieve the desired outcome. You're adapting to the challenge. Second, habit learning. This leverages the fact that habits, whether good or bad, are incredibly hard to break and are particularly resistant to forgetting. This relies on different brain pathways than declarative memory, making it a powerful target for intervention. CREST specifically targets key cognitive domains. For prospective memory and planning, which is remembering to do things in the future and organizing steps. Strategies include extensive calendar systems. This means daily checking, weekly planning, and entering both events and reminders prior to events. Other strategies include linking tasks, associating a new task with an automatic already existing habit, using automatic places, keeping items in the same designated spot, utilizing to-do lists and sticky notes with calendars, and short-term strategies like writing reminders on one's hand, leaving messages, or using visual imagery and can't-miss reminders. For cognitive flexibility and problem-solving, which are crucial executive functions, the program teaches a structured 6-step method for problem-solving. 1. Define the problem. 2. Brainstorm solutions. 3. Evaluate each solution based on ease, costs, benefits, consequences. 4. Select the solution to try. 5. Try it. 6. Evaluate if it worked. If not, go back to step 4. Cognitive flexibility is enhanced through brainstorming, strategy verbalization, hypothesis testing, actively looking for evidence that disconfirms their beliefs, and practicing set shifting, trying a different strategy if one isn't working, versus set maintenance, keeping a strategy that is working. These cognitive rehabilitation techniques are integrated with standard organizational strategies found in traditional CBT manuals. This includes categorizing items to keep and discard, developing filing systems, designating specific places for discarding, like for donations or recycling, ensuring adequate storage, using organizational items, containers, shredders, developing rule systems like everything has a final resting place, setting up staging areas for items, and implementing maintenance systems to keep cleared areas clean. This comprehensive approach addresses both the cognitive challenges and the behavioral aspects of hoarding.
So this more comprehensive approach, combining traditional CBT with cognitive rehabilitation, does it actually work? What do the studies say about its efficacy? Because for someone struggling or supporting someone who is seeing tangible results, well, it's key.
The outcomes are truly very promising, especially when you consider the intensive and often chronic nature of hoarding disorder. Looking at CBT outcomes more broadly, a Wallace-controlled trial showed that CBT led to significantly greater improvements in hoarding symptoms, including clutter, excessive acquisition, and difficulty discarding after 12 weeks compared to a control group who received no treatment. The mean scores on the saving inventory revised, a primary measure for hoarding symptoms, decreased by about 15% from baseline in the CBT group, with virtually no reduction in the waitlist group. The demographics of the completers were insightful: 78% women, 89% white, mean age 55, with high rates of comorbidity, 46% major depressive disorder, 35% generalized anxiety disorder, 24% social phobia. These improvements continued to be seen at 12 and 26 weeks, showing continued symptom reduction, though achieving and maintaining subclinical status often remains a longer-term goal. In this controlled trial, 71% of participants were rated by their therapist as much or very much improved, and 81% by client rating. A significant 46% achieved clinically significant improvement. This clearly suggests that CBT specifically adapted for hoarding disorder is indeed effective. Now, when we look at cognitive rehabilitation plus exposure sorting therapy, CREST outcomes for geriatric HD, the initial pilot study results were even more striking. This study, which included 11 participants with a mean age of 66, showed significant reductions in hoarding severity measures, such as the Saving Inventory Revised and the UCLA Hoarding Severity Scale. Importantly, these results were significant even when depression or anxiety symptoms were factored out, suggesting a direct impact on hoarding itself. The profound impact seen here is that treating these neurocognitive deficits in older patients with hoarding disorder appears to double the improvement rates for CBT, moving from potentially 15% responders in CBT alone to 38–40% responders with the combined CREST approach. This suggests that CREST is not only feasible and acceptable for older adults, but also highly promising for enhancing treatment response. While the pilot study had limitations, a small sample size, no control group, and no long-term follow-up, these results strongly advocate for further research and application. Finally, let's briefly touch on pharmacotherapy. Historically, hoarding symptoms were thought to be largely resistant to medication. However, recent findings are more promising. SNRIs, or serotonin noradrenaline reuptake inhibitors, such as extended-release venlafaxine, have shown efficacy. Open-label trials for individuals with a primary hoarding disorder diagnosis demonstrated mean SIR reductions of 36%. Some individuals achieved a remarkable 60% reduction in symptoms without concurrent psychological therapy. Some patients even preferred this to CBT. Psychostimulants like methylphenidate have also been examined, particularly due to the comorbidity with ADHD. They showed mixed and modest improvements, though acceptability issues led to unanimous discontinuation in one study. More research is definitely needed on combination SNRI CBT therapy and the broader efficacy of psychostimulants.
It's truly encouraging to see such dedicated research leading to more effective targeted treatments for this challenging condition. It really highlights the importance of diagnosing this as a distinct disorder rather than just, a symptom of something else.
Precisely. Yeah, the independent classification of hoarding disorder in the DSM-5 has been a critical step forward. It has facilitated dedicated research, allowed for specialized training, and led to the development of more tailored treatment approaches like the adapted CBT and CREST. This shift moves beyond seeing it merely as an OCD symptom, allowing for more accurate understanding and ultimately more effective pathways to recovery. #outro.
Wow, what a deep dive into hoarding disorder. We've gone from its precise definition, unpacking the DSM-5 criteria, and understanding the profound impact on living spaces and functionality. We've explored the subtle but crucial differences between hoarding and collecting, distinguishing passion from impairment. We've also delved into the fascinating interplay of cognitive deficits and specific brain activity, giving us a clearer picture of the why behind the behavior. And finally, we've walked through the specialized, evidence-based treatments, particularly those tailored for older adults, that are making a real difference.
To connect this to the bigger picture, understanding hoarding as a distinct disorder with specific cognitive and neurological underpinnings truly transforms how we approach it. It shifts the perspective from judgment, which is so common, to a nuanced understanding of a treatable condition. And that offers real hope, not just for individuals struggling with hoarding, but also for their families and communities.
To recap some key takeaways from our deep dive today, hoarding disorder is a recognized psychiatric condition, formally distinct from collecting. It's defined by persistent difficulty discarding, accumulation of possessions that compromise living space, and significant distress or impairment. It's driven by complex factors, including genetic and experiential vulnerabilities, specific information processing deficits in areas like attention, memory, and executive function, problematic beliefs about possessions, and powerful emotional reinforcement, both positive and negative. And finally, specialized cognitive behavioral therapy, particularly when augmented with cognitive rehabilitation strategies like CREST for older adults, shows significant promise, offering tailored strategies for organizing, managing acquisition, and crucially, for discarding. So what does this all mean for you? Perhaps it's a new lens through which to view clutter in your own life or someone you know, maybe prompting a more compassionate and informed response. Consider this. If our brains are so intricately wired to make decisions and yet can get stuck in patterns like hoarding, what other seemingly simple daily struggles might have deeper, fascinating cognitive or emotional roots that we haven't even begun to unpack? This deep dive reminds us that even the most seemingly mundane aspects of human behavior can reveal profound insights into the workings of our minds,